Well, I want to thank all the speakers. There were 3 excellent talks from my colleagues, Professors Khunti, A.Amiel, and Linda Gonder-Frederick. I think we've covered a broad range of topics there in hypoglycemia, and it would be great if we could have some questions, which you can either do if I believe the slides are in my control now, or maybe not. And here we are. We're now up on the Zoom meeting itself. There is, if you look at the bottom of your screen, here we go. No. You can add in questions either directly now through this meeting or through the Q&A panel that accompanies the live stream. And I think I might kick off with one question from Dr. Shikar. For yourself, I think, Linda, would you name one of the psychoeducational programs and what problems would be addressed and discussed with the patient?
Yes, there's several. A number of them originated in the UK. That would include the Daphne program, dose adjustment for normal eating, and then another version of that, an evolution, which is the Daphne Heart program. There's the HYPOS program, HypoAware, HypoCompass. Amsterdam, the Netherlands, has created a program. There's one in Germany as well. They're all good, and they all have nice, strong data to back them up. And in terms of what would be covered, it would be a variety of things, and it would differ somewhat from program to program. But I would say that all of them would cover behaviors that contribute to more problems and to a higher risk. Also, self-assessment is important for people to understand for themselves what their own attitudes, beliefs, and behaviors might be that are contributing to the problem. General education about hypoglycemia, which actually is in many countries and many clinics is very inadequate. People don't understand the basics of hypoglycemia and why they need to treat it immediately and quickly, and because of inadequate understanding of neuroglycopenia and what happens with that. I'm open to talking to anybody about these programs. If you wanted to email me at some point, we could have a longer discussion.
So can I, just before we go to another question, the panel, follow that up, Linda, and perhaps even Stephanie. Do you think you had an interesting slide there about different, perhaps, phenotypes of those people with impaired awareness? So I can think, you know, in the clinic of the individual who every time their glucose levels gets to 10 millimolar or 180 takes a bolus of insulin, versus the individual whose HbA1c is 11%, doesn't look like they've seen hypoglycemia for the last 6 months, but tells me that they have a loss of awareness and run themselves high. So they're very different type of characters. And how might you approach this individual or these individuals?
This is a relatively, and Stephanie, I do want you to chime in, a relatively new area. And as for the people who are so concerned about high blood sugar levels and developing complications, that's an interesting group of people that Dr. A.Amiel's group from King's College and my group from University of Virginia kind of ran into and identified with different experiments. I think clinically it's a very important group that has been understudied, and we need to do a better job because it is a high-risk group, definitely. Dr. A.Amiel, do you want to add?
Well, no, thank you. It is a really interesting question because, as Linda pointed out, one of the commonest drivers of problematic hypoglycemia is, in fact, the desire to keep away from hyperglycemia. And the programs that Linda has mentioned and her own blood glucose awareness program should perhaps be included in that. These are programs that many of those programs started out as educational around how best to use insulin flexibly and worked because they help people avoid hypoglycemia. but increasingly they are now focusing on the cognitions around hypoglycemia, and trying to help people understand what barriers there are in their thoughts about hypoglycemia and about diabetes and control in general, that might be preventing them avoid hypoglycemia. I also think we have to recognize that there's a dissonance between what some of the healthcare professionals believe and what the patients want. The patients want to avoid complications as well, and are very focused, many of them, on keeping the blood glucose control in the sort of area that minimizes their risk of long-term complications. And just telling people that to avoid hypoglycemia, they can relax their control is not a message that is at all acceptable, and rightly so. And many of these programs now are much clearer about saying what we're about is avoiding hypoglycemia and maintaining the avoidance of hyperglycemia and helping people to do that better. Specifically in regard to your question about the people who seem to have hyper-awareness and yet very poor control, we're just beginning to look at the sorts of people who might develop hypoglycemia problems more than others, and there are just hints that attitudes such as perfectionism are really important. The people who are very perfectionist tend to be going for very tight control and may drive themselves to hypos in that way. The people who are completely non-perfectionist may be at the other end of the extreme and not concentrating enough on their diabetes control in order to avoid hypoglycemia. And that might be the group of people that you're describing, Rory, with the high HbA1c and the hypo problem.
Well, I might follow that up there, because Dr. Shakir has asked how to deal with brittle diabetes. And if you'll remember the poster session yesterday, one of the risk factors for diabetic ketoacidosis was prior severe hypoglycemia. And so I wonder about that. So that is that type of individual, isn't it? And what might your thoughts be if someone like that came to you in the clinic?
I think you have to start the conversation to find out what the patient is prioritizing. And if that's something that is problematic to them, avoiding the hypoglycemia, then you need to address that directly. And increasingly, there are problems where we're currently in the middle of a randomized controlled trial of one program that is specifically designed to try and deal with that, work out what the patient is thinking and why they seem to be experiencing the hypo problems, what it is they're doing that's driving them towards hypoglycemia and why they're doing it. And if you can work out the motivation, you can then have the discussion about changing the behavior.
Okay, and Stephanie, I hate to stick with you again, but one of the earlier questions from Daniel Milic was, how do you think the low accuracy of currently available CGM devices, especially in the hypoglycemic range, is going to impact on the management of people with impaired awareness?
So I think that's a really good question. We've got some other people on the panel now who might be better able to discuss the deficiencies and advantages of CGM than I. I think we already find, and I'm sure everyone in the audience has experienced this, we've got patients who will not use particular technologies because they don't feel they're accurate enough. And that can be a problem. I think we really need to understand what CGM diagnosed hypoglycemia really means, and it is going to be different according to the accuracy of the technology that you're using. And Bastian is on the panel now and is leading a European consortium to try and, which one of the things it's trying to do is understand exactly what the clinical correlates are of CGM diagnosed hypoglycemia, because we see these long periods of nocturnal hypo on CGM and we've got no idea if they're terribly dangerous, if they are completely irrelevant. We really don't know. And so I think that is something we need to discover. And the technology is advancing very rapidly. The CGMs are becoming more and more accurate. And then it's just a question of understanding what those low readings on CGM mean. But Bastian,
okay, thank you very much. I don't know whether Bastian wants to comment briefly on this.
I just came online with it, so I missed part of the initial conversation. But I agree with Stephanie, and I thank for pointing that out. That we are having a large consortium looking at the impact of hypoglycemia in a large population and trying to sort of refine and solidify the classification of hypoglycemia as has been published in this position paper by the IHSG a couple of years ago, which is very good, I think, but the evidence supporting that classification is still quite limited. So we try to provide this evidence more in a more robust way.
Great, thank you very much. And if any of the other panelists want to come in, that would be fine as well. Another question that has come up, and Kamlesh, I think you might hopefully be able to comment on this one, is about the use of sulfonylureas in the frail elderly patient, where of course there is the risk of hypoglycemia, but of course the cost benefit that we're all drummed into is in the NHS. Kamlesh, would you like to come in on that?
Sure, Rory. Yeah, I mean, sulfonylureas, they're like Marmite. You like them or you hate them, as you know.
Yeah.
But we still use them. It's with the DPP4 inhibitors in the UK and globally from the Discover study. They're the second most commonly used therapies after metformin. And first of all, we need to think about 80% of people with type 2 diabetes live in low middle income countries. We need to think about that, first of all, in terms of the cost implications. Sulfonylureas, I think they've had a bad press, but overall, if you look at the evidence, in terms of randomized controlled trials, especially the second generation sulfonylurea, so you look at glycoside, glimepiride, they have a pretty good safety profile if we use them in the appropriate people. Obviously, if someone has episodes of hypoglycemia, and this is when we may need to think about either reducing the dose or stopping the therapy, but we spend a huge amount on drugs, but we don't give any impetus on educational programs. If we can just give educational programs to people with type 2 diabetes, this is what I'm talking about, type 2 diabetes, at a reasonable cost. We know it costs about £30, €30 per year to give an educational program. You can empower that person with diabetes to recognize hypoglycemia, tell us about the hypoglycemia, even manage their hypoglycemia well. So I think overall, we would still be using sulfonylureas, but the guidelines are changing. When you look at the evidence base for cardiovascular outcomes, there are a proportion, 25 to 30% of people with cardiovascular disease and renal disease. We have high quality evidence of the therapies such as SGLT2 inhibitors and GLP-1 receptor agonists. In the other groups, I think it's still reasonable to use sulfonylureas.
So I'll push on that a little bit, Kamlesh, and particularly for your own data, which showed the high frequency of severe hypoglycemia in the elderly. And there are populations whom we have not included in many clinical trials, and there are debates even about whether the diagnosis of diabetes impacts on your mortality once you're over the age of 70. So do we need to think about more specific guidelines for the management of elderly people, largely in the way of doing proper controlled trials in this rapidly expanding cohort?
Rory, you're absolutely right. So first of all, we do have a lack of data from randomized controlled trials in these groups, as we do with the young type 2 as well. Very few trials have done in people aged 50 years of age. Only 1% of people are aged under 50 in many of the trials. And the elderly are avoided well. When we look at elderly, sometimes we need to think, is it going to benefit them in terms of reducing HbA1c? Someone aged 75 with diabetes, they will have about 1 to 2 years of life years lost compared to someone who doesn't have diabetes. And about 50% of that may be due to diabetes. And that's where we start thinking, do we really need to go for a tight target for this patient? Or is that a time when we may stop the sulfonylurea and let their HbA1c remain slightly high? And there are a number of consensus documents that have come out. Alan Sinclair has a number from the Primary Care Diabetes European Society. We've produced some position statements. But you're absolutely right. We do need trials in this population.
And a follow-up question from your own talk, Kamlesh. You were talking obviously about the real-world data on severe hypoglycemia. There was, again, another interesting presentation yesterday from Alex from the INFORM study in Canada, which had looked, as you know, retrospectively over the patient history of severe hypoglycemia, and that was picked up from healthcare organizations, suggesting that we only picked up 5% of the true frequency of severe hypoglycemia. What are your thoughts about this?
Well, this is what I mean. When we look at retrospective studies, most of them are either recall, when we ask patients, or they're large database study. The systematic review I showed of those over 40 studies with 500,000 people, majority of those are retrospective studies. First of all, retrospective studies are under-reporting hypoglycemia because milder forms of hypoglycemia are not captured. It's mainly severe form. If people are hospitalized, there's a payment for it. And that's why they're recorded in large databases. But we miss all the mild forms of hypoglycemia. And this is where we need to pick. We've already heard from great talks today. If we avoid the milds, we will avoid the severes. And the only way we can capture the milds and the severes accurately, as we showed from the HAT study, is by doing prospective diaries. And these studies, one of them I showed in a primary care hypoglycemia group, was a year-long diary events, but we don't need a year-long. 4 weeks of diaries is good enough, and that's where we will capture accurate data on hypoglycemic episodes.
Okay, fantastic. Now, a follow-on question, and I guess for any of the panel, or Stephanie or Linda, from A.Amiel, who works with Simon in Sheffield, saying, how do we better clinically phenotype impaired awareness of hypoglycemia in the older person with type 1 diabetes? Because of the issues around GOLD, which is around, it's fairly rough and ready, if you like, and relies on patient recall. There is cognitive decline in the elderly purpose, which might limit performance in some of the tools that we use. And he's mentioning whether we should use blinded CGM and corroboration with patient diaries, although, of course, there are limitations on CGM in the elderly in this context. So any thoughts? Again, it's raised this issue about the lack of data we have in the elderly, who are a growing population worldwide and are at such risk of severe hypoglycemia.
Yeah, I think one thing that we could think about is having an assessment protocol for different patient subpopulations. And actually, I've never thought about it that way myself, but I think that might be quite useful to think about it in that way. All of the methods you mentioned are perfectly appropriate, even in older adults. There can be problems with recall, but depending on family members for recollection, I think is very important in that age group. Prospective data collection, as Dr. Khunti is pointing out, is invaluable. Stephanie, what do you want to add?
I think you've said most of it, Linda. I think the critical thing with a patient where you are not sure, and I'm not sure this is age dependent, and I agree with you, we need studies specifically in the elderly, but the critical thing is asking the people who know the patient if the worst witness of their hypoglycemia experience is the person with unawareness. If they're unaware, they're unaware. And so they cannot tell you about the experience they're getting because they don't know. Which is one of the reasons they don't focus on trying to avoid hypoglycemia. So I think perhaps particularly in the elderly where there may be issues, it is critical to be able to talk to someone who knows the person with diabetes and can describe the problem. Very often, and again, I wouldn't say this is dependent on age, it's the family members who are particularly concerned about hypoglycemia. Their worries are often higher than that of the patient themselves, particularly in the setting of impaired awareness. So I think you use the tools that we've got that have not been shown to be age dependent, but then you add, well, in anyone, you add the look at the glucose evidence from diaries and CGM, being cautious with CGM, because one of the things that is still bothering me is that we don't see much difference in the hypoglycemia recorded by CGM between people with awareness and unawareness. And that is odd based on what we think we know about unawareness, but certainly looking at that, and then asking the people who live with the person if it's an elderly, frail person, and bearing in mind that hypoglycemia itself can interfere with cognition and memory. And so the person who's really troubled by hypoglycemia may be behaving worse than they might because of the hypoglycemia. So I think it's a very good question and one that actually requires further research.
So Stephanie, while you're there, there was a comment in the Q&A just to say thank you for mentioning the patient perspective. And I wonder, do you think that we've done enough of that, highlighted the perspective of patients and their carers in terms of hypoglycemia, the concern that it raises, and also impaired awareness?
Not officially. So I think we're all very conscious of the problem, and I'm sure we do all talk to our patients, sometimes our patients' carers. I would point out, as far as I'm aware, there are no programs available for the relatives of people who live with people with diabetes with hypo problems. And so the simple answer to your question, because I do tend to go on a bit, is no. We haven't taken enough notice of the patient's voice. And I think that's beginning slowly to change. There's a big patient input into Bastian's EU study, but we, as always, we need to be listening to our patients.
Okay, I haven't seen as many questions as I thought I might see on how much is enough in terms of reduction in hypoglycemia. If I were sitting here representing industry, I might say that the trials required to demonstrate reduction in severe hypoglycemia are going to be so large that they're going to want to focus very much on level 2 hypoglycemia. And so could you expand on that a little bit about what we might think is sufficient?
So we said that about cardiovascular outcomes. And now we can hardly market a new product without a cardiovascular outcome trial. I agree with you. I mean, happily, severe hypoglycemia is not common enough to be a frequently reported endpoint in trials, unless you do the trials in the people who have the problems. And that's where you can see significant reductions. And obviously, that's where you want to start, because those are the people who've got the problems. Again, I think greater understanding of the implications of the non-severe hypoglycemia in terms of severe hypoglycemia risk. And I think one thing that the patient voice is telling me is that patients are more worried about non-severe hypoglycemia than we are. So have I answered your question? I think we have to keep our eye on the main outcome, which is to stop severe hypoglycemia. We've got a few... But there is a good reason to stop non-severe hypoglycemia also. What I do think we need to avoid is making claims for treatments around severe hypoglycemia where there aren't data to support it. And I think running trials in high-risk groups is where you will be able to get that sort of information.
Okay, I think that makes sense. So there's one other question, which I will again open up to the audience here rather than making you answer these all, Stephanie. It was, how would you manage hypoglycemic episodes in those patients with documented diabetic autonomic neuropathy? And if we take that as a surrogate for people with complex, probably end-stage, multi-organ end-stage disease, so the frail individual who has multiple microvascular complications related to their type 1 diabetes. Would anybody like to pick up on that question?
Well, if no one is...
there you go, there. Thank you, sir.
I'll start, perhaps they can shoot me down. I mean, the first thing to do always is to make sure that there's no other comorbidity. I mean, you don't want to be missing hypothyroidism or hypoadrenalism that's easy to treat in assessing the patient with hypoglycemia. Otherwise, personally, I do what I do with anyone who has a hypo problem. So we review the level of expertise the patient has in the management of their diabetes therapy. As Linda pointed out, where you're talking about type 2s, which is, my practice is almost exclusively type 1 now, but in type 2 patients, you've got the option of reviewing the therapy and picking something with low hypoglycemia risk. And that's particularly important where you can do that with type 2. But otherwise, you look at how they manage their regimen, and if simply correcting any potential errors there doesn't work, then you need to move through to the sort of more psychologically informed programs that look at why the patient is having a problem, struggling. You use technology, of course. I mean, if you've got CGM, you've got the sort of hybrid closed loops. These things are particularly useful if you've got access to them for people with type 1 and problematic neurological issues. and ultimately, as Linda pointed out, you have the option of transplantation now, at least in some centres. So I would personally take them down the same profile, same pathway that I would take my other patients: medical review, education, sort of psychologically enhanced assessment, and if necessary, intervention, technology, perhaps those two running together or one after the other, and then ultimately the sort of transplantation options, because those are the tools we've got.
Okay, fantastic. So I'd like to also bring in our colleagues. We have colleagues joining us on the panel from Japan and from China, where I think the phenotype of type 2 diabetes and type 1 can be very different in terms of this matter. And most of the trials, of course, are still done in Western, in Caucasians. So do you think there are differences within, let's say, the elderly population in Japan or China, which might merit a different approach, or even in terms of how we phenotype impaired awareness? Any broad comments you have on the conference so far? If I start with Yingying, if I start with you in China first of all, and then we'll go to Munhada in Japan.
Okay, sure. So very good questions. But actually, I think now we do not have enough data to show that how much difference do we have compared with the Westerns, compared with Caucasians. So actually, I think maybe because of the pathophysiology between Chinese population and the Caucasians might be different, because maybe the beta cell function is not as well as the Caucasian. So I think the risk of hypoglycemia may also be different. But in the future, we should do more epidemic studies to show how much difference do we have compared with Caucasians. But now I don't think we have enough data to show that. Okay,
I think you're right. And in Japan?
Yeah, I think I feel almost similar between Japan and Caucasian people. Especially quite different is in Japan, in elderly patient is very growing now. So, and 1/3 of severe hypoglycemia causes by sulfonylurea, and 2/3 of severe hypoglycemia causes by insulin treatment. So therefore, we have to concentrate how to use the sulfonylurea in elderly patients. And also, we found, so the dose of sulfonylurea doesn't matter the cause of severe hypoglycemia. Small dose of sulfonylurea is also causes severe hypoglycemia. Therefore, we have to also check the dose of sulfonylurea. And in type 1 diabetes, so situation is very close. However, we cannot use artificial pancreas. We only can use insulin pump 640 Medtronics. That's all. Therefore, we only can use the suspended glucose system alone. Therefore, we still have many big problems in advanced insulin treatment in type 1 diabetes condition. Okay, can you understand?
Thank you very much. Yeah. Stephanie, you wanted to come in here.
Just very briefly, I mean, the low glucose suspends are actually transformational in preventing severe hypoglycemia. I just want to make the comment that, and that's great that people do have access to that. I just want to make the comment, they do not restore awareness, and so they only work while you're wearing them. And that's an important thing for the patients to understand.
Kamlesh.
I would like to add a little bit more. I think there is actually a big problem in China, which is the lack of education of hypoglycemia, especially in the elderly. Actually, they do not have enough education about the hypoglycemias. Maybe this is a common problem in all the developing countries. So I think this should raise our awareness of maybe improve our education to all the populations. Thank you.
Kamlesh?
Yeah, that's the same situation in Japan. We don't have enough educational system. So that's the reason I attend this international hypoglycemia study group. Okay.
Rory, just a quick one. I think this is a huge program of work we need to look at. All the data on hypoglycemia has been based on white European populations. The CLAMP studies are done mainly in white populations. we see differences when we look at the HAT study, huge higher rates in Indians for severe hypoglycemia. We've seen that there are differences in the perception, how people convey their symptoms of hypoglycemia in the UK when we compare whites with South Asians. We really don't know whether it's the same levels of cutoffs for hypoglycemia for certain ethnic groups. And this is an area that we need to look at. There may be cultural differences, but there may also be pathophysiological differences as well. So
Kamlesh, and thank you very much. Linda, I'm going to have to cut you off because I noticed that it's 8:29 and everybody is going. So suffice, I want to thank the panelists, and of course I want to thank the three main speakers for providing excellent talks today, and I think it's generated a lot of interest. To my mind, some of the things that have really emerged, apart from determining what level we need to try and avoid, are the lack of data in the elderly population. I think that's something that we need to address. I think we need a more global approach to the study of hypoglycemia, as you've noted. And I think finally, a very interesting area is around how we subtype the different types of impaired awareness of hypoglycemia, both and going forward. I think that's interesting. And then at the end of it all, if Simon were here, he would say the same thing. I think that education is clearly the priority for all of us. It's the most effective way to reduce hypoglycemia.
Thank you.
And I think he would be keen that we draw that forward. So once again, I want to thank all my panelists. I hope you enjoyed the rest of the EASD in this new virtual setting. I hope you found this a very informative and rewarding meeting this morning. So take care, look after yourselves, and goodbye to everybody.
Bye.
Thank you very much. Bye.